this is a significant safety signal, and it should spur real deep investigation into what are the actual adverse events coming from the use of mifeprex the way we're doing it. But even more than that, this is a signal that the removal of the safeguards in 2016 was foolish. And it was foolish because we're seeing an increase and an increasing number of adverse events.
Hi there, and welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, or AAPLOG. On this podcast, we bring on experts to provide insights to support you as a medical professional in your life-affirming practice and career. I'm your host for today, Dr. Christina Francis, board-certified OBGYN and CEO at AAPLOG. I want to quickly acknowledge that this week's episode was originally going to be part 2 of the conversation we started last week. However, since then, an important update has emerged that we felt we needed to discuss on this podcast. So we're going to interrupt our previously scheduled programming just for this week. But don't worry, we will get right back on track next week with the second part of our important conversation on forging a new path forward in medicine. And in fact, that new path forward couldn't be any more important because of this breaking. So last week, 2 reports were published by the Foundation for the Restoration of America and the Ethics and Public Policy Center based on the largest known data set identifying prescriptions of mifepristone, the most common abortion drug. These data sets were drawn from insurance claims data from all major payers across the country. The reports find that 10.93, so nearly 11% of pregnant women who took this drug suffered severe adverse events as a result, a rate that is 22 times higher than the less than 0.5% severe complication rate that the FDA currently reports. This rate means that in 2023, roughly 71,000 women would have likely suffered complications such as hemorrhage, sepsis, and more. So this is a really significant issue that I know for those of you who are medical professionals, you are seeing the fallout of these drugs in your own practice. Here today with us to talk about these papers and their potential implications for medical professionals, as well as public policy, is AAPLOG's very own CEO Emerita, my predecessor and current Director of Research, Dr. Donna Harrison. Dr. Harrison, thank you so much for being with us today.
Thank you, Christina.
It's so great to have you here. So Donna, can you start by just giving us a summary of these reports? I said that they drew this data from insurance claims data, but can you just kind of give us a summary of what these reports looked at and what they found?
So yeah, I can. So what these reports looked at is they looked at private insurance claims data, de-identified so that there's no way to get to the patient from these reports. And they looked at what was billed. It's very simple. If a patient was billed for mifeprex with a code that said elective abortion, then that was considered that she had a mifeprex elective abortion. Or if she had, another kind of coding that would clearly indicate a mifeprex abortion, that's the inclusion criteria. And they looked at, I'll just get the number for you here, 865,727 mifepristone abortions from 2017 through 2023. And that's how they identified the serious adverse event rates. So what they did was they looked at the FDA definition of what is a serious adverse event, what the FDA includes in their own consideration of a serious adverse event. And they did not take adverse events that happened that were not serious. So it's important to understand that they looked at using, they qualified serious adverse events in the same way that FDA qualifies a serious adverse event. And that's what they reported on.
Yeah, absolutely. Well, and they looked at 45 days out, which is pretty typical. That's about 6 weeks or so, 6 weeks and 3 days out. So a lot of times that's sort of the short-term range that we'll look at to see if somebody has an immediate complication, right, related to an abortion. And as you said, then they use the diagnosis codes that correlate with what the FDA defines as serious adverse events, and found a nearly 11% serious complication rate.
Yeah, it's not surprising when you look at data, registry other studies, such as Finland. When there were registry based studies published back in 2009 and 2011, looking at what are the complications for women who took mifeprex for abortion and misoprostol in roughly the same regimen that we're looking at now. What kind of complication rate did they have? And it's very, very similar to other registry based studies. And the important thing is, this is a real world study. This is what happens to people on the street. This isn't a carefully controlled clinical trial. When the FDA looked at their adverse events, they looked at carefully controlled clinical trials. And in those carefully controlled trials that were looked at, all the women, or almost all the women, had ultrasounds for determining gestational age. They were closely followed by physicians. A clinical trial, there's very close scrutiny. But what you're seeing now, and as evidenced in this database, is what happens to real women that aren't in a clinical trial, real women that haven't had an ultrasound to know exactly how far along they are, women that are getting these drugs without maybe any physical exam, without ruling out ectopic pregnancy. That's the importance of this study, is it shows what's really happening to women.
Yeah, absolutely. And I think it's important to point out too the date range at which they looked. So it started in 2017. So that was after the FDA made their first major changes. And for anybody who regularly follows AAPLOG in this podcast, you should be well versed on all of the changes, the very reckless changes that the FDA has made regarding mifepristone, the abortion drugs. And so our listeners may know, but if this is your first time listening, in 2016, they changed the number of in-person visits that were required from 3 down to just 1, so no follow-up visits. They expanded the approved gestational age range for the drug from 7 weeks to 10 weeks, knowing that that would increase complications. And at the same time, they said, you don't have to tell us about adverse events anymore. The only thing you have to report are deaths. And made it so that non-physicians could be dispensing this drug as well. And then, of course, in 2021 came the most egregious change of all of them, which was to remove that in-person dispensing requirement, which essentially led, and I think it's an important point to make. I think people hear, oh, it's telehealth abortion. So people have, I think, in their mind that a woman is sitting down on a computer conversing like you and I are right now with a physician who's going into detail about her personal history and all of that. Maybe that's happening sometimes, but we know that the vast majority of these women are filling out a form online and these pills are being shipped to them. That's it. Really no meaningful interaction whatsoever, with all the dangers that you outlined, not knowing how far along they are, not ruling out an ectopic pregnancy. And if you look at the raw numbers that these papers reported of the complications, while if you look at the ectopic pregnancy rate, it might look kind of low, I think it's important to point out that it still was over 3,000 women that had an undiagnosed ectopic pregnancy, which is life-threatening. Yeah. And with a nearly 11% complication rate, that's about almost 1 in 9 women who suffered a severe adverse event. And yet women are being told that these drugs are safer than Tylenol, which of course you and I know is not true whatsoever. But yeah.
Yeah, it isn't true. And what's even worse, Christina, and what I think women should be up in arms about, is that there's no knowing how far along in pregnancy a woman is when she's actually taking these drugs. From your clinical practice that when women come in, we do an early ultrasound, and it's pretty frequent that we have to change the due date because she's a month further along or a month less far along than she thought she was. And why is that important? Because these women are not getting informed consent. How do we know that? The further along she is, the higher her risk of complications. We know that from other studies, registry-based studies overseas that have looked at the gestational age and the complication rate. And even the FDA knows this, that if she's at 7 weeks from the first day of her last menstrual period, she may have a 1 in 25 chance of going to the ER. If she is at 12 weeks, just a little more than a month later, then she's got a 1 in 3 chance of having to have surgery. So this is the kind of thing that a woman would want to know before she decides, am I going to have a surgical abortion? Am I going to have a chemical abortion? And women are not getting informed consent on this.
Right. Absolutely. I mean, you and I both know we're both OBGYNs. And, I think any medical professional listening to this who's ever given informed consent to a patient knows you have to individualize your informed consent. It is not a blanket consent for anything, Even a C-section consent is going to vary depending on how many C-sections she's had before, how long has she been in labor. There's so many factors that are individual to that patient. And women deserve better informed consent so that they can make a fully informed decision and understand the potential risk that they are taking on. And as you said, they're not being given that. And I agree with you. I think this is something that it shouldn't matter where somebody stands on the issue of abortion. We should be united in this, that women deserve better than this. They deserve to know the true risks. And the FDA should be doing a better job of evaluating the risks that are actually happening. If this was any other drug that had nothing to do with abortion, the FDA would have taken a hard look at this a long time ago, and they would have never deregulated it like they have now. I think we all know that there's political motivations that have been there in the past when these changes were made that really sacrificed our patients' safety. I want to move on to our next question because I know we have a lot of other things to talk about, but go ahead, Donna. Did you have something else on that?
I was just going to say, it is really almost unbelievable that the FDA would relax required safety restrictions and then say, don't report any complications. Like, I can't imagine why you would do something like that.
Well, talk about the definition of burying your head in the sand, right? I mean, that's exactly what they did. Like, we know there's going to be more complications, but we don't want to know about them. So, and so speaking of that, and the FDA's, the rate that is often quoted from the mifepristone label of less than 0.5%, this is how they could keep claiming that it's such a safe drug, of women have severe adverse events. Can you talk a little bit about a couple of reasons why these numbers from this data set might have differed so much from that less than 0.5% that the FDA claims?
Well, if you want to dig into it, you should go to the FDA mifepristone label and read pages 5, 6, and 7. And what you find is that in order to calculate that 0.5%, it appears that FDA didn't include hemorrhages. And they didn't include surgeries. They just included a very small set of complications. And they also did something that looks like they were doing some mathematical calculations that actually don't make any sense clinically. So I think that we have a little bit of gymnastics going on at the FDA to come up with a 0.5% figure when they know full well that about 5% of women hemorrhage after this. And you've got 4 to 5% who need surgery after this. And those were just blanket excluded from adverse events. It makes no sense.
Right. Absolutely. Well, and we were talking a little bit about this offline over the last few days. And, they included women who needed transfusions, but not women who had hemorrhage. Well, if a woman starts out with a hemoglobin of 13, she could drop her hemoglobin to 8. That's a significant hemorrhage.
That's right.
She might not need a transfusion with a hemoglobin of 8, but she still had a massive blood loss to drop her hemoglobin by 5 grams. And maybe she didn't need a transfusion because they intervened with emergent surgery to stop her bleeding before she needed a transfusion. But again, that's not included in their rates of severe adverse events. And I think most women would consider massive hemorrhage and the need for emergent surgery to be a pretty significant adverse event.
Yeah. I agree. That's just common sense.
Yeah, exactly. So, yet another example of the FDA burying its head in the sand, and add to that what you referenced earlier, which is that the FDA's numbers come from highly controlled clinical trials, which definitely play a role. I want people to understand this very clearly. Donna and I are not saying that clinical trials are not valuable. They definitely are. But the whole reason the FDA has post-marketing analysis and vigilance over the safety of drugs is because they recognize that oftentimes when we use drugs, any kind of drug, in the real world, the adverse events and the outcomes, all of that look different than they did in that highly controlled environment. And so the FDA is supposed to follow that. And in fact, history is replete with drugs that looked safe in the clinical trials and then proved to be unsafe and were pulled from the market after real world use. Vioxx is probably one of the most famous ones that was pulled because of, there being vigilance and complications happening, and then the FDA responding to that. All right, so I do want to address, there's already been several attacks on the reports on these data, and so I want us to think critically through those and give credence if credence is due to some, but I think more of it is just sort of thinking through what are the limitations potentially of this kind of data and what are the benefits of this kind of data. And one of the things that I think we have to address is that there is a difference between causation and correlation. And certainly with insurance claims data, we cannot prove conclusively a causative effect. However, as we discussed at the beginning, they were able to look at a woman who received a prescription for mifepristone. Now, do we know that she took that? No, maybe she got it and she didn't take it. We can't tell for sure from the insurance claim. However, if that same woman then shows up in the ER 2 weeks later with a diagnosis of incomplete abortion, most likely she took the mifepristone and now she's got an incomplete induced abortion. So can you talk a little bit about that? Because it is true that we cannot claim causation definitively, correct, from this data. But what can we see from this data?
What we can see is women who have an exposure, which by any stretch of the imagination means that they had the abortion, they took the abortion drug, and then they have a complication which clearly can be related to the abortion. You just gave the perfect example. Retained tissue after having been given a prescription for mifeprex and the need for surgery. That's pretty clear. Now, we can't prove it, but we can infer causation. So causation is the kind of thing you can't prove anything is caused by something else. What you can do, though, is to look at what's called the Bradford-Hill criteria for inferring causation, and those take into account the temporal sequence. Did the thing that you're looking at happen before the adverse event? How closely was it related? Does it make sense that it was related? All of these things. And in this study, all the adverse events that they looked at, the severe adverse events, were all logically related to mifepristone and to the process of abortion. Now, you could say, well, an ectopic pregnancy isn't related to mifepristone. A missed ectopic pregnancy is related to the fact that the abortionist did not give an exam that ruled out ectopic pregnancy and gave the woman mifeprex, which is contraindicated with ectopic pregnancy. And so she has at least a delay in diagnosis. So that is an adverse event that happens by the way mifepristone is being given. So there's not only what the drug does, but the way in which the drug is used. And right now, the way in which it's been used is dangerous for women. Without a diagnosis, a clear diagnosis, without ruling out ectopic pregnancy, without knowing how far along she is in gestation. We've talked about that already. But it's the manner in which it's been given that is contributing to these severe adverse events.
Yeah, absolutely. Well, and I think the other important thing to point out, as you said, is does it make sense that this adverse event would have followed from the administration of this drug? Yeah. What do we know about mifepristone? We know that it increases risk of hemorrhage because it has an effect on nitrous oxide synthesis, and it causes dilation of the spiral arteries. For those of you who are not OBGYNs like Donna and I, that means that it makes it harder for the uterus to stop bleeding from the main arteries that are feeding the placenta and that growing, developing baby. And the way that the uterus will stop bleeding is to close off or constrict those spiral arteries. Well, mifepristone actually counteracts that contraction of those spiral arteries. So it increases the risk of hemorrhage. This is not pro-life conjecturing. This is basic pharmacokinetics of this drug. We also know that mifepristone increases the risk of infection, specifically one kind of infection from Clostridium sordelii, and that can lead to horrible sepsis that we've seen reports in the news, even just in the last few years, of women who died from severe infections after taking mifepristone. So these are things that we know occur related to this drug. And, I think the benefit of this insurance claims database is it's not reliant upon how the FDA has set up for adverse events to be reported. Right. Which, let's talk about that. Donna, can you go over, for people who aren't aware, back even when they were requiring, which of course now they're not requiring anything be reported except for deaths, but what is the process of a complication getting reported to the FDA? I really want people to hear this and understand it.
So the FDA required that the manufacturer, Danco, submit all adverse events that they knew about to the FDA. So Danco then required the abortionists to submit the adverse events to Danco. And so you can see that there's a lack of incentive for submitting adverse events from the abortionists to Danco and from Danco to the FDA. And I, along with the team of a bunch of other physicians from AAPLOG, actually reviewed all of the adverse event reports that were submitted from 2000 to 2019. And some of them were so egregious, you could tell that the abortionist actually didn't know what happened. There were things in the adverse event report. There were some descriptions like patient bled, went to ER. That's it. No blood pressure, no hemoglobin, no details. So it's incredibly deficient, the whole entire system. And then Christina, you had the experience of trying to report an adverse event. And did you want to talk about that one?
Yeah, absolutely. Well, so once I even learned, and I'm somebody who's sort of deep in this issue, and I didn't know for a long time that there was a way of reporting adverse events to the FDA. Once I figured that out, then I started reporting the complications that I was seeing. First of all, to report it to Danco, you had to print a paper off. You have to print it off the website, fill it out by hand, and mail it into Danco. So first of all, that's a huge disincentive, obviously, for sending those in. And then the first time I tried to submit it then myself on the FAERS website, the FDA adverse event reporting system, it took me 2 hours to get it submitted. Probably it's very rare for any other busy physician to spend 2 hours trying to get it submitted, but I was committed to knowing that the FDA knew about this complication that I had taken care of. After that, it never took me quite that long again, but it still is a very cumbersome process. And so I think it's very easy to see why the adverse events reported to the FDA would be significantly less than what's actually occurring in true clinical practice.
Well, the other interesting thing about the adverse events, I have to mention the paper by Christine Cerrucci, where she looked at adverse events that were published by a woman named Cleland, who looked at adverse events at Planned Parenthood clinics for a year. And she took that information and compared it to what was on the FDA website. And there were thousands of adverse events that theoretically happened, never made it to the FDA website. So it's very interesting, the discrepancy of what's reported. And maybe the problem was with Danco, and maybe the problem was that they were never actually reported. But there's a discrepancy. So what you see on the FDA website, even in the past, is a gross underestimation of the actual adverse events. And that's the beauty of this study. There's no issue of reporting here. This is billed information. If there's inaccurate information, that's Medicaid fraud. So there's a lot of motivation to accurately report. So as accurate as the insurance claims database is, that's as accurate as the study is.
Yeah, absolutely. Well, and I think you and I both agree that this is a very large database that these groups access.
Yeah.
And for sure there needs to be there needs to be peer-reviewed papers that come out of this database, really drilling down on what is the true complication rate. But I think as we wrap up here too, what we want to leave too is, what are we as an organization, as AAPLOG, what do we want, first of all, medical professionals, other doctors out there to know, or what do we think they should maybe do or change their clinical practice, based on at least the information that we have right now from the reports on this data? And then what are we asking the FDA to do? What do we think is really important that comes out of this? Again, acknowledging the limitations that it has with the kind of data that it is, but also acknowledging that this should serve as a significant safety signal,
Right.
For both practicing physicians and the FDA. So just kind of recap for us, what do we think people should take from this? And then what do we want the FDA to do?
I think you said it. This is a significant safety signal, and it should spur real deep investigation into what are the actual adverse events coming from the use of mifeprex the way we're doing it. But even more than that, this is a signal that the removal of the safeguards in 2016 was foolish. And it was foolish because we're seeing an increase and an increasing number of adverse events. If you looked at the EPPC paper, there's an increasing number of adverse events as the state safety restrictions have been removed. So at the very least, the FDA needs to backtrack and go back to the pre-2016 safety constraints that were there. Elements to assure safe use is what it's called. They need to go back to the pre-2016 elements to ensure safe use. And that involves a woman seeing a physician in person and unbelievably getting a diagnosis before mifeprex is given. And what they should implement is an ultrasound to show where the baby's at and to make sure that there is no ectopic pregnancy. Now, I don't care how good you are as an OB-GYN, you cannot rule out ectopic pregnancy all the time by physical exam. It just is not physically possible, especially at early gestational ages. So they should go back to following up on a patient. What a thought. You have a drug that you know leaves retained tissue. You better make sure that woman doesn't have retained tissue after she thinks she's completed the abortion. And there should be things like ROGAM instituted. Right now, these women, because they're not being seen by anyone, either before implementing ingesting the mifeprex or afterward to follow up, the Rh negative women are not getting ROGAM. That is a potential disaster in the next 10 to 15 years. And we also should consider pulling this drug from the market. I think that has to be part of the considerations because the safety concerns are so high, and there is an alternative, surgical abortion, which has less complications.
Right, absolutely. And I think pointing out too that this is a drug being used for an elective indication. We are not treating a disease process when this is being used for induced abortion. And also pointing out, I thought of one other sort of criticism that I've heard of these reports that I know we're going to link in the show notes to a fact sheet that EPPC put out that shows that they actually excluded unrelated ER visits from the analysis. So if a woman broke her arm 2 weeks after she had an abortion and went to the ER for that, that was not included in these ER visits. And they excluded non-severe adverse events. And that is detailed in their fact sheet. So I'd encourage people to look at that. Also, they excluded women who might have been prescribed this drug for a miscarriage. And so really did due diligence to only include women who were taking mifepristone for an elective induced abortion. So I think that's important to point out. Sometimes if a drug is treating a really severe life-threatening disease, we tolerate a higher risk profile, right? Because the benefit outweighs the risk. That is not the case in this situation. We have a risk 1 in nearly 9 women will have a severe adverse event for what? For a completely elective indication. And so, we owe the women of this country better. We owe the preborn children of this country better too. If women truly understand the risks associated with this drug, I think that fewer women will choose to have an abortion via that way. And as you said, for those women who still are going to choose to have an abortion, there would still be, in states where it's legal, surgical abortion would still be an option. So absolutely, bare minimum, we are calling on the FDA to reinstate the original safeguards that the FDA itself recognized were necessary for this drug to minimize these kinds of complications. But we are also calling for them to at least start doing a significant investigation into whether or not this drug should actually remain on the market as well, again, due to the significant safety concerns. So again, we will link to all of these documents that we've been talking about, the studies that Dr. Harrison referenced in the show notes. And if you want to, and we'll also link to the 2 papers that came out, and we want to thank the Foundation for the Restoration of America and the Ethics and Public Policy Center for getting this information out there. And hopefully this will, as we talked about, spur deeper research, peer-reviewed papers, and significant information that will be out there so that we can continue to help our patients. Donna, Dr. Harrison, thank you so much for joining us today. Donna is our resident mifepristone expert for sure. So thank you so much for sharing your expertise with us today, Donna.
Thanks for letting me be on.
Absolutely. And thank you so much to our listeners and our watchers for joining us today. If you find this content helpful, we invite you to support our work by joining today. If you are a medical professional, you can go to applog.org/join. If you're not medical, but you care about ensuring that accurate medical information is out there, and that when you want to find a pro-life physician, you can find one, we also join you to support our work. Partner with us and support life-affirming medicine. To do that, you can go to applog.org/donate. If you liked this episode, be sure to give us a like and subscribe on YouTube, or if you're listening on a podcast app, give us a 5-star review. We'll see you on our next episode.